That sounds like really important
It does.
official music.
Well, I tried to go through and pick all the newsy kind of music for this, so yeah. But hey, welcome to Last Month in Healthcare. I'm Nathaniel Smith. I'm with...
What's up, man? And Spencer Smith here, host of the Self-Funded with Spencer podcast, and super excited about this new format, man.
Yeah.
That's cool.
New thing we're trying out, once a month, audio only. Although if you watch it on YouTube, there are the PowerPoint slides. They're not going to add much, but they're there.
There's some good pictures, I think. I got a little sneak preview, but didn't see the whole thing. And so the premise is this, too, is to review the previous month and what happened, kind of big stuff in healthcare, but you don't give me any heads up of what we're going to cover. So it's supposed to be like organic responses and stuff.
So that is part of this.
I'm a little nervous.
I put this all together. Spencer doesn't know what I'm going to talk about. So, I mean, we'll see what he wants to keep in, what he wants to keep out, but I'm in charge of the edit. So,
well, whatever they hear is what we decided they get to hear. So, all right, cool. Well, let's do it, man. So last month in healthcare, we're going over February of 2025. Let's do it. All right. A little kind of generic hair metal, like 80s rock.
I went through and got all the rock metal. I literally went through like 15 to find that. They're all too intense. But
that's a good jam, dude. All right.
So the first podcast from last month. So I guess we should introduce the self-funded review. I thought it'd be fun to go through. We released 4 podcasts last month. So every one of these we can go through and say, Spencer, we were actually recorded, people don't know maybe behind the scenes, like we recorded these in like October, November last year. So interested to see your thoughts since they've come out, since you've recorded these on these topics. So the first one was with Guy and Robbie, Insurance for Organ Transplants. Here's a clip from it.
People call us, that's when we get a little nervous because now the house is on fire. And the first comment I make is, you don't buy the homeowners after half the house is burned down.
So that was I picked for all these little
Guy
intro
Finley,
clips.
By the way,
He's great.
Well, so he's absolutely right, though. At least what he's positioning, it's a fully insured kind of organ transplant policy where they carve that risk out from a stop loss policy and separately cover the things related to a transplant. But he's right. Hey, you can't. It's not like you could do this mid-year when somebody's already getting a transplant. So his idea was like you need to sort of think about what the risk looks like in advance and determine is it worth obviously carving this risk out and paying for it. Guy Finley, I've known him for a number of years, like a sweetheart of a human being. I'd got a chance to sit down with Robbie, who's their chief product officer as well. Great guys, great company, and honestly, like believe it or not, question around organ transplant carve-outs came up this morning in a conversation I had with brokers. And I don't have a ton of opinion or a strongly held opinion either way, but I could be compelled. I think there's a good story, and it really comes down to what we think our risk looks like and the financial impact of paying for a separate policy or just leaving it in stop loss. So it's up to the listener to decide if it's useful or not.
Sure.
Yeah.
So did you get any interesting response to this one or?
They just kind of more wanted to know my opinion. I had a couple people that reached out and said they didn't even know this was possible, which is kind of cool, just even planting the seed in their mind of like, were you aware that there's entities that do this? But ultimately, it was just one of those really good ones that I'd never actually featured the subject before. So it was novel for me to get a chance to sit down and talk to him as well.
Cool.
Yeah.
All right, so the next one was with Shelby Cowley. Here's a clip from hers.
Other than a broker, as the word you use is consultant, I hear that time and time again, that you really have to be that strong advisor, that consultant to the clients to stand out and show that you can really bring true value to them and think outside of the box.
Yeah, so that actually was one of my favorite podcasts so far. I know we shot it last year, but released this year because she's such a wealth of knowledge in mergers and acquisitions and did a lot of, I think 187 is the number of acquisitions she assisted Acrisure in doing on the buy side. Now she's moved on the sell side, which is like, how do I represent sellers to help position them to get maximum value for their agency? So really cool economics of like, how do you value an agency? What are the multiples? What's the runway to prepare for it so you get maximum dollar, like when you should do it. And I think it was a master class in something that most people aren't privy to unless they're going through it themselves, either on the buy or sell side. So awesome episode.
Yeah, I think that was technically our second private equity guest, right?
It was, yeah. So I have to give a shout out to my buddy Kyle Coots, who was our first Private Equity 101 episode a couple years ago. 36,000 views on YouTube, by far and away the most watched podcast episode of all time. But that was more generic understanding private equity and how they evaluate buying and selling businesses. This was specific to the insurance brokerage industry, so which is a little bit more specific, but probably very useful for some of my listeners who are likely going through this thought process right now of like, how do I sell my agency and what is it worth and how should I evaluate it? My hope is that one or two people got something that actually could apply to their own business from that episode.
Well, it's also relevant. I didn't include it in the later on. We're talking about headlines and stuff, but there was an article I saw about how more private equity is going into healthcare as opposed to like the big tech because it's a more safe bet, I guess.
Healthcare is one of those industries that sort of transcends all the ups and downs of the macro economy. Selfishly, it's a safe haven from a career perspective as well.
Yeah.
So it's not surprising that a lot of entities are looking to sort of park money in healthcare or use it as an investment vehicle.
Yeah. All right. So the next episode's with your boy, Sean Wood.
Oh, Shawnee Wood.
Be kind, be focused on others, be a steward of your craft, and take the opportunity to take action and execute on something that's greater than your own good.
So I got to give out,
message.
Yeah, Sean is an amazing communicator. So what Sean does for us at Pareto, he's a head of our national accounts. So super strategic mind. The guy's always playing like 4D chess. The joke they always talk about, like in the world of politics. He's playing 4D chess, and it's actually really interesting to watch his brain work. And it's just it's phenomenal the way he operates. I would say this episode was had a 25% faster pace than all the other episodes average. And I think it's
viewership?
Yeah, viewership. Yeah. Because I think Sean's network is super strong. He came from ADP, so there's tens of thousands of people that know him from that. And I think it was just a great conversation that's more than just healthcare. It was about sales leadership as well.
Cool. All right. So the last podcast last month with Maggie.
Maggie Quinn, yeah.
Yeah, Maggie from Intrepid.
You're not going to be excited when I'm calling you. We're probably not a mutual fit. And that road works both ways, right? Like, I'd rather not work with clients that they call me and I'm like, oh,
you look at the phone
they're calling me again. No.
Maggie is one of the most well-liked people in the industry. I think it's anybody that ever brings up the name Maggie Quinn, it's like people, I love Maggie. I know Maggie.
I think Scott Smith.
Yeah.
I've heard him talk about her multiple times.
So Intrepid is part of, I think they're definitely part of True. I can't remember if they're a Patriot growth agency or not, but they have a long-standing relationship. They're a great partner of ours as well. And Maggie's just one of those people that just universally is liked and loved in the industry as well. But I think the interesting angle that we took is just their particular office is a female-led or an all-female, basically run agency, which oftentimes our industry gets pegged as a old, pale male and stale, and so they're the antithesis of that. And whether or not we have to worry about male or female or whatever, they're successful. And their clients love them, and so it's working for them, and I give them kudos for that.
It was interesting to me because I heard about them before, but she mentioned on the episode that it wasn't intentionally all-female, which is kind of funny. Like, it's just they naturally ended up all-female. So
yeah, they didn't put a sign on their door that said women
not
only. They're not discriminating. And I think they've had a couple men that have worked there for time one time or another, and it just didn't work out, but it wasn't intentional. And I think now it's to the point where it's kind of part of their brand, which is pretty cool as well.
Cool. So now I would say the next part's the main segment of the show.
Okay.
It's called Healthcare Headlines.
Yeah, and I have no idea what news we're going to cover. Make America healthy again.
Another newsy.
Yeah, I was feeling like there'd be
intro.
like a zoom in and it'd be all dramatic and hi, welcome to the news,
I mean, that's basically what we're doing.
Okay,
It's
cool.
Healthcare Headlines. So, so the first few, I put this, if you're looking on YouTube, we're looking at the screen here, the Make America Healthy Again hat, because I think that's probably the biggest news story recently. It's February. It's right after the new administration came in late January. So the first few, and I would bet, if we keep doing this, the first few stories on each of them are probably going to be about this for the next few months at least.
Yeah.
So the first one, I was looking through the Make America Healthy Again executive order just to see what's interesting. I wanted to point this out. The first mission that they were given was fighting childhood chronic disease.
Yeah.
But it's actually more than you would think. It's the scope of it. So they're talking about any potential contributing causes, American diet, absorption of toxic material, medical treatments, lifestyle, environmental factors, government policies, food production, electromagnetic radiation, and corporate influence. So it's kind of everything, which is, I just think is interesting. I mean, like it's also that's with any chronic disease, but specifically.
Well, what I think about is interesting is how this idea of make America healthy again is so polarizing. It's politicized because it's attached to Trump, and obviously he's a pretty polarizing figure. But ultimately, what we're talking about is some things that everybody should be, I would feel, get their minds around. Like, how do we look at our food system, the entire food system, the chemicals that we're spraying on the food, the additives in the food, whether it's seed oils or high fructose corn syrup, all these things. I don't see why it would be unreasonable to take a very serious look at those things that feed into the health crisis and start to question the use of those things. I think that's apolitical.
I mean, I think fighting childhood chronic disease is pretty apolitical.
Yeah,
I don't think anybody's going to
so.
take the stand on the side of chronic disease.
Well, and I would say it's inarguable the poor health status of the United States in aggregate. Like, I think it's very difficult to argue against that. We have a real serious issue, and I think it does tie into healthcare because the expense side that I always talk about is a direct function of the poor state of health that most Americans have on average. And so if we can attack that, which is a root cause issue, then ultimately I think we'll see better outcomes in healthcare expenditures and the things like that over time. But this is also a generational play. This isn't something where we do it today.
Well, you see the benefit of this later.
Multi-generational play.
Yep.
And I'm honestly glad we're taking the stance. Again, I don't think it's political. I have a Make America Healthy Again shirt that my buddy Jonathan Lopez gave me. I wear it proudly. I talk about health and food and nutrition and exercise all the time. And I'm glad that it's actually an active part of this administration.
I forgot to play this clip earlier. I'll just play this.
Right,
I don't know if I'll leave this in, but
Make America healthy again.
I thought it was funny.
Please leave that in.
Okay, I'll leave that in. So the next part was the healthcare price transparency executive order. I actually texted you about this when I saw this.
Okay,
But here's actually him talking about it.
Okay.
A couple of people that actually going back a long way that feel that are real pros in the industry feel this is the biggest thing you can do for cutting prices. It's been unpopular in some circles because people make less money, but it's great for the patient. It's great for the people in our country, okay?
Yeah, so without knowing the specifics, I mean, price transparency has been something that was part of the previous administration as well with the CAA. There are requirements where hospitals have to provide pricing data, but the problem is they provide these enormous files that are only machine readable, and it's very ugly, like dirty data.
Right.
And so you have to create software that can parse that information and clean it up and make it accessible. So without knowing the specifics of what he's trying to do, ultimately the belief is that if we start to get free market forces to apply to healthcare and we get hospital systems having to compete on price and a price that's transparent, it should equate to lower costs. And I think that premise at least is sound. And I'd have to dig into how he's doing that, because this isn't new or novel.
How effective this is, too.
Yeah, how effective this is and what is new versus what is already sort of supposedly the law. But the issue is like the law doesn't get enforced very well and there's no punishment for not following it. And so ultimately, I guess I would say TBD on how effective.
Wait and see.
Yeah, wait and see.
Yeah.
There's so many dollars and there's so much influence in healthcare that's going to lobby against these things that it often ends up a stalemate.
Sure. Well, that's kind of was wondering your take on that. I feel it the same way. It's like how effective is the executive
if
order?
it's attached to who it's attached to, ultimately there's always going to be people that fight it. And so I would love, and I'm always hopeful that, I think there's a term that says the best disinfectant is sunlight, or sunlight's the best disinfectant. And so the more exposure that our industry has on bad practices, I think that's generally a good thing.
Sure. All right, so next, this is your favorite topic.
What is it?
Steak and Shake says all locations will be, quote, RFK'd as they swap vegetable oil for a healthier beef tallow to cook their iconic shoestring fries.
All right. Well, this is timely because I did have Steak and Shake beef tallow fries with my buddy John Lopez again last week.
Okay, when's the last time you went to Steak and Shake before that?
I can't remember. I mean, they had one when I was in Springfield, Missouri for college 20-some odd years ago. There was one there, and I may have gone there once or twice. Okay. So literally, I was like, I can't remember how they used to taste, so it's a really bad taste test comparison.
That's what I wonder, too, because it's not like they taste like beef, right?
No, honestly, they taste like French fries. They taste like really good French fries. They weren't super soggy. I don't know if that has anything to do with it. But, I mean, I would, from like a taste perspective, great tasting French fries.
Yeah.
I think the one thing, and again, this is an anecdotal study of one circumstance, didn't have any sort of discomfort or bloating that typically accompanies eating that type of food. Granted, I had a burger, no bun, and did my usual stuff, but the fries didn't like destroy me for the rest of the day. So maybe there's something to that. There's people that sort of disagree that seed oils are bad for you. I think it remains to be seen, is that technically true? But if you look at the process of how they create these seed oils, and you think the origins of like what seed oils used to be before they got into food, it's actually pretty gross. But yeah, anyways, I think it's a good thing. Fewer ingredients, in my opinion, is always better, and the more natural those
whole foods,
more
kind of thing.
Like, this is weird, but I use face lotion a lot, and I tried whipped beef tallow. Honestly, it sounds crazy, right? But people are like, "No, beef tallow is great for your skin." So I tried this like manufactured whipped beef tallow, and it was fine. It wasn't greasy. My wife would be like, "You kind of smell weird," so I stopped wearing it.
That doesn't smell like beef, though, right?
No, it's not like you rubbing a steak on your face.
Yeah.
Like, it's obviously cleaned and everything.
Yeah.
But I think, again, this is just a specific instance in which the Make America Healthy Again policy is being applied to the food system.
Right.
Time will tell how effective it is, or if this just optics.
Or if other people adopt it.
Yeah. Well, other people have. I forgot the other burger place as well, but somebody else has announced that they're doing beef tallow fries too.
Yeah.
So maybe we have a beef tallow movement. I don't know.
Because I wonder, I guess, they're still unhealthy, right? I think that's.
It's still French fries.
Yeah, they're still French fries.
But if it's beef tallow, potatoes, and salt, at least you know exactly what the ingredients are. There's obviously the question of like, how much does a processed carbohydrate impact the starch, impact your blood sugar, and insulin response and stuff. So on balance, is a French fry good for you if it's in beef tallow or seed oil? Probably not.
It's still a little bit of a net negative.
Yeah,
but it's better.
Agreed. Yeah, but it might be incrementally better for you at this point, right? Who knows?
All right, so next, I have a little montage of these commercials. It's talking about the telehealth companies boosting ad spending.
Amazon One Medical. Feeling good just got better.
Losing 15% of your body weight is possible with Ro.
Hims & Hers offers life-changing weight loss medications. They're affordable, doctor-trusted, and formulated in the USA.
So I thought this was kind of interesting because when I read this article, I was thinking, I guess I don't associate the like Hims & Hers and Ro, like the ones that do Ozempic or Wegovy and stuff. Like, I don't associate those with telehealth, but they are, because they get you a little doctor's appointment.
Well, the things they prescribe or require a doctor's order
right.
for that prescription, so they have to be able to use telehealth to do it. Yeah, it makes sense. But keep going. Sorry.
No, I was just gonna say I think it's interesting. I mean, it's a weird thing where it's like they are reaching consumers directly, right? So there's not the middleman of insurance and whatever. It's just saying, hey, do you want to buy this drug? You get on a call with us and pay us $200 or whatever and give you the drug.
Yeah.
Like, I think that's a good thing in a way. Like, I wanted to see your take.
So it's interesting because if you think about what they're really doing at scale is making drugs more accessible.
Right.
And whether that's good or bad depends on the specific use case or application. But, if there's a very low barrier to entry or low effort in order to get to a doctor, have a conversation that's typically required to get access to a drug, that doctor thinks it's appropriate and writes a prescription, and they immediately turn around and mail order these drugs to them. I mean, they've solved a real serious problem, which is the amount of effort required to get access to the drugs you think you need.
Yeah.
They also, I think, help from a privacy perspective if maybe somebody's wanting to get access to ED medication, right? That might be embarrassing to go to your doctor's office and ask for. Well, if I can get it through a virtual visit and it's, obviously still HIPAA protected, but I don't have to do anything to have my face be seen in public, going to the doctor. I think for situations like that, and Hims & Hers, I think, is doing like hair loss medication. They're doing a lot of the GLP-1s now as well. And so I say kudos to them for creating a system that sort of eliminates some of the friction in getting access to drugs. Now, is it good that it's so easy to get access to some of these drugs now? That's a different conversation.
That's the next slide, actually, is related to that. So I went to Benefits Pro. They had this article I thought was interesting about the GLP-1 stats saying 1/3 of Americans would switch jobs just to gain access to GLP-1s, which is crazy to me. 54% of Americans are on GLP-1s or want to be. And then from February 2024 to February 2025, employer-sponsored coverage has gone from 30 to 63%.
That's actually pretty interesting. But let's go through all of those. Like 1/3 of Americans would switch jobs to gain access.
Well, to be fair, it was switch jobs or they'll keep their job and won't leave even if they don't like the job kind of thing. So it's like, I think it was both of those.
Well, I mean, if you take a step back, what it speaks to is people are people want access to these drugs because they believe in the efficacy of the utility of these drugs. They think, oh, I can lose weight, and that's a good thing. And I've struggled my whole life in order to lose weight, and nothing's been successful. Maybe this GLP-1 that's so popular right now could be the thing that does it. I think we're looking at this being the first or second biggest drug category of expenditure in the United States this coming year. So relatively, I would say low-ish price point, but the size of or the number of people that are on it is astounding. And I worry the number of people that may be on it for more than often than not vanity reasons. Which,
non-medical,
not in an obese state where it's like the trade-off is if I'm obese and all these other comorbidities come with it, I should do something versus I need to lose 10 pounds for the summer. This is the easiest way to do it. I worry about the risk-reward profile in that situation, and I think a lot of people are leaning towards, oh, it's just an easy way to lose weight, and I just inject myself once a week. That's scary. It remains to be seen what the kind of side effect profile over time looks like. This one, though, the last one is pretty interesting to me that employer-sponsored coverage has gone from 30 to 63%.
Yeah. It's crazy.
It's crazy.
Went from a third to over two-thirds.
Yeah.
Or around two-thirds.
And I suspect a lot of these folks are in a fully insured plan that might include it in coverage. We see in our business a much lower percentage of people in the self-funded world that are covering them for weight loss alone.
Really?
They're actually electing not to cover them for weight loss alone. Or put some sort of triage mechanism to prevent people from just getting it because they want it. And so this is actually surprising, at least from a coverage perspective, that many employers are now covering it. Kind of crazy.
Federal judge sides with the FTC to move case against PBMs forward. So the FTC, they announced this in November that they're suing Caremark, which is CVS, Express Scripts, which is owned by Cigna, and then Optum Rx, owned by United, for alleged price fixing through discounts, which we talk about all the time, or you talk about all the time on the podcast.
Yeah, so, I don't know what the exact allegation is around these discounts, but if we just talk about the discount model in general, and how that sort of hides the actual cost of the drug because you're just looking at discount and not the actual price. What happens in these worlds is oftentimes the price of the drug will be raised so that a big discount can be applied, and therefore that looks great. Oh, I got it on sale, right? Just like you were shopping and got something on sale. But ultimately, they ignore sort of the actual price of the drug after that discount and what you paid. And so I would love if we we eliminated rebates and we eliminated discounting and we just said, this is the price of drugs, maybe put a small margin on top of it.
Like the cost-plus model.
Cost-plus model. I've got a pharmacist out of Fort Worth that's coming on here in a couple months that is talking about Doge and how he's been able to identify all this Medicare waste with his cost-plus model of pharmacy, where he gets the drug at a certain cost, he adds a couple bucks on it, and he sells it direct without insurance at all. I mean, that's a free market, in my opinion, versus this type of model. And so I would love to follow this over the next couple of months and see how this suit progresses.
So I thought this was an interesting juxtaposition. This is two different articles. So one is facing burnout, U.S. doctors see hope in AI for better patient care, and then study reveals majority of U.S. adults distrust healthcare systems' use of AI. So I thought this was a crazy stat. 93% of doctors feel some level of burnt out, and 80% think that AI will relieve some of that stress in their workload. And then 65% of American adults do not trust AI in healthcare.
Well, this contradiction on the surface, it looks surprising, but it's not. And so let's talk about each one of them. The burnout is real. That burnout is, especially in like the primary care world, there's a huge amount of burnout where people realize the quality of life for them as a doctor in that world is so poor, the hours are so long, and the pay is not commensurate with that. So they're getting burned out. That's real. AI could help with things like taking notes, transcribing those notes and putting it in the electronic medical record, storing that record over time, symptoms checkers. There's all sorts of really interesting things where it's doing kind of the tedious work on behalf of the doctor so they can focus on patient care. So I have no doubt that it's going to improve the quality of life of the physician.
For sure.
I think the skepticism around American adults is that they've seen the application of AI in denials for claims. If you obviously remember the Luigi Mangione thing that's going on the last couple of months, some of that was around denials of claims, and AI plays a role in automated denials. And then it's really hard to go back and get those denials approved. and you just have a system that's designed to deny,
Yeah.
which on the surface looks like that healthcare insurance company is trying to save money, and they'll just point, oh, it's the AI, it's the algorithm that did it, it's not us. Yeah.
Sure.
And they might use a third party to have arm's length. And so, yes, there's inherent mistrust and well-founded mistrust in AI in that particular application for sure. What's your thoughts?
Well, do you think at a certain point, I was having this conversation with Dustin the other day about, which Dustin's a videographer we work with, but about, there's a weird thing I feel like I would probably count myself in the 65% that don't trust it, just because I was talking about like even, I'm thinking more indirectly in healthcare, like in the care that they're giving you, right? Yeah. The idea of like, I would way rather have a human surgeon do a surgery on me than a robot, right? Even if the robot's like 99.9% and the human's like 98.5%, I'd still be like, I don't want to die at the hands of a robot. I don't know. It's weird. It's a weird, like, it's the same thing with self-driving cars, right? It's like, I would rather be behind the wheel, even if it's on paper, like way more safe for me to be in a self-driving car. You know, it's like,
well, I get it. It's a removal of control. And I would agree with you on the self-driving cars. Like, I'm very, very scared of self-driving cars, but probably wrongfully so.
Sure.
But I think if you're talking about, that's more robotics than just AI, and I totally get that. But I think just like everything, the precision that a robot can do things at is far superior to a human.
I think they already use it. Like they use the robot arms and stuff like that.
But I think it's still the doctors involved in utilizing the robotics on their behalf to be more precise or something that's really small in scale. But it's not, the doctor's not sitting out, just observing on a computer screen. Yeah. So I don't doubt it. I think Americans in general have a distrust of AI because we've seen how some of them are programmed and some of the slant that's programmed into the algorithms. And so they're like...
And all the movies that have been coming out for 50 years about...
how we're all going to die because AI is going to take over. So I think it's probably like, what do they call that? It's there's a type of programming where they basically foreshadow in movies like things that might come in the real world. Predictive programming.
Okay. Oh, yeah.
So they sort of like prime people towards a future event that's probably going to come, and they obviously leverage fear around that event.
I think if that's true also, though, how have we not had an alien invasion? We've had a million alien movies, not had that happen yet. But
I haven't been bitten by a vampire either, but there's countless werewolf and vampire movies and stuff. But so I'm probably wrong. But anyways, fun conversation.
Next is another AI thing. It's a bill proposed to allow AI to prescribe drugs. So I guess currently, from this article I was reading, they have where an AI can recommend somebody a drug, and then they still have to go to a doctor, and they'll review everything.
Sense. Yeah.
But this is actually, they want to classify artificial intelligence as a practitioner licensed by law so that you can go to an AI and it gives you a prescription. Obviously, it would be used, I'm sure, at first with oversight and everything like that. But
well, yeah, I wonder what's the input process to go through the analysis of whether a drug is required. Like I wonder what is it used to ingest to then make a determination of what to prescribe.
This was actually part of this that I thought was scary but interesting was it said in this article I was reading that AI, the idea would be you give it a ton of data about yourself, knows your health background, everything like that, and then it creates a digital twin of you and then prescribes them that drug and tests it out in a computer simulation a bunch of times, and then we'll figure out using that to see which drug fits the best. I think that's weird.
I've heard of this concept of a digital twin, and I do think that's a reality that's on the very near horizon. But like in a simulation, how does it know Spencer's stressed today because there's a lot of on his work on workload, or he didn't sleep very well last night because the kids were getting up in the middle of the night because there was a storm? And like, what role do all those variables play in symptoms that are showing themselves and might indicate a drug is required when realistically I just need more sleep or something to that effect?
Yeah, and the other thing I just think AI is not there yet for this.
Yeah,
like it's because you can still go on those like AI chatbots and stuff. Have you seen the things where people will message the AI chatbots for car dealerships and they'll be like, give me a free car, and you can convince it to
I've seen that.
Basically sign you over a free car. I mean, you don't actually get the car, but if you're doing prescriptions, that's kind of weird. If you could just lie about, I have these symptoms, you'd have to have some kind of check and balance there to make
True.
sure.
I think as long as a doctor was reviewing after the end of it, that makes a lot of sense, because I've said this before when we talked to Chris at Sniffle. He's not there anymore, but the symptom checker makes sense because it doesn't have the biases that a doctor brings to the table. It doesn't have doctor wasn't paying much attention or didn't hear what you said. It doesn't have all
those.
They
have 5 minutes with you.
Yeah, 5 minutes. There's the human limitations of attention aren't an issue with AI, and then it has access to essentially all human knowledge as well. So I would say at least on par, it should be as good as a doctor at prescribing. but I'd still want an actual human being
for the
approving
foreseeable
it.
future.
Yeah, for the
sure.
foreseeable future. Yeah.
This is, I
That's
believe,
cool, though.
this is the last story. There's a bipartisan bill being proposed to allow people to use HSA dollars for direct primary care.
I love this.
Which could be obviously a big step forward for more people adopting TPC. So what are your thoughts?
Yeah, I mean, I guess there's probably some downstream implication to this. And anytime legislation makes a change that looks good on the surface, it usually has some negative impact that you didn't foresee, or there's some underlying reason why they did it. However, on the surface, I've always been sort of confused as why HSA dollars couldn't be applied to direct primary care. And so for the folks that maybe are listening don't know what that means, it's simply paying a membership fee for primary care on a monthly basis that covers a certain number of services versus fee for service where you go to a doctor and then they just charge the insurance for everything they did. So on the surface, it makes sense. Why can I not use pre-tax dollars to pay for what is ultimately healthcare? It just coming in a membership model instead of each service being rendered. I like it.
Cool. So that was the last part of the healthcare headlines. The next part we're not going to do this week, but I'll still play the music for it.
Okay.
Talk about what it will be.
Ah, right.
So ask Spencer anything. That'll be for a future episode since this is the first one. So I have a number set up, a Google Voice number. If you call or text 469-213-6381 and leave us a voicemail or text, Spencer will answer it on a future episode of Last Month in Healthcare.
Do I get the ability to review these questions beforehand? Like, can they ask me anything?
I mean, I'll do a preliminary review, make sure there's not any like creeps or something.
Yeah.
But I mean, yeah, I don't want you to hear them ahead of time. For
Okay,
sure.
all right, cool. Well, that's actually fun. We did this once before.
Yeah.
We did a
Yeah,
live
for a live
episode
show.
with this, and it was actually really, really fun to do. So looking forward to doing that next week or
Cool.
next month. Excuse
Next
me.
month. Yeah. So that's the first episode of Last Month in Healthcare.
Dude, that was
What
fun.
do you think,
how,
Spencer?
how long was that? That was like 20.
We're at 33 minutes. I mean, I'll cut out some minutes of that. So
Yeah, cut out most of the stuff
Yeah.
I said that sucked. But honestly, I really enjoyed that, and I have to applaud you. That was phenomenal, your preparation for this and like everything you did. This is super cool, and I definitely want to do it again.
Awesome. Thank you.
Awesome.